Hello. Welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this session is the first part of the Follow the Money portion of this series and entitled Healthcare Prices, Costs, and Payments. This module is targeted to Level 2 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, such as interventional radiology or nuclear medicine, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to describe differences between prices, costs, and payments when it comes to healthcare services in general and radiology services in particular, to understand how costs vary considerably from payer to payer, provider to provider, and patient to patient, and to integrate information about out-of-pocket patient costs into discussions and recommendations about the appropriate use of imaging in individual clinical circumstances. Here are some additional references listed alphabetically by author for those who would like to learn more about the topics in this module. How much will that study cost? It's a question we occasionally get asked by referring physicians when trying to decide between two different imaging tests. And, as a general rule, it's a question that most of us as radiologists are poorly equipped to answer. But that question is asked a lot more commonly by our patients before they even step foot in our hospitals or our imaging centers, completely unbeknownst to us as radiologists. Unfortunately, when they ask questions at the time of scheduling their examinations or when those examinations are performed, our team members are equally unable to answer those questions very well. And it's not because they don't want to help. It's because there are so many variables that go into the equation. The complexity of this issue will be the focus of this module. The issue at hand is price transparency in healthcare, or more accurately, the lack thereof. It's something getting a lot more attention, but for which robust solutions are still lacking. Price transparency is something we all expect as non-healthcare consumers. Take these Walmart shoppers. They know exactly how much something is going to cost them before they put it into their shopping carts. That information allows them to be informed consumers and to make intelligent choices to buy something or not. As shoppers in the age of the internet, it's something we've all grown accustomed to. Here's a screenshot of a recent Amazon shopping cart of mine. Whether I'm buying things I'd normally buy at the grocery store or the hardware store, I know in advance the exact price. And I know how much it's going to cost to ship it and what day it will arrive. That's real price transparency. Some prices may seem transparent, but really aren't. As I'm recording this session, I just made my airline reservations to attend the 2017 RSNA annual meeting. When I purchased my tickets on Delta, I could tell exactly what I was going to be paying, depending upon when I wanted to fly and in what type of seat. But those prices change sometimes day to day and sometimes hour to hour, and vary a lot depending upon where your connecting flights are starting and ending. So people who may be sitting right next to each other on the same plane may be paying very different amounts for essentially the same seats. Buying a car is perhaps the worst of all these experiences. The ads in the newspaper always look enticing. But at least for me, when I show up at the dealer, the individual car being advertised has invariably been sold, and the most similar one is now priced quite differently. Lots of prices in the ads have asterisks after them, suggesting that what you see is not necessarily what you get. And so the price of the car you buy often depends a lot on your negotiating skills and how much homework you've done prior to the sale. That introduces a lot of inequities into the process. Research done nearly 20 years ago revealed that such non-transparent pricing disproportionately disadvantages women and people of color. That same probably holds true for healthcare services and other services in other sectors as well. It's important to note that this isn't because those individuals are in any way inferior. It's probably more related to the fact that they, at least back then, weren't playing the game as well. And the way to advocate for yourself in the game of shopping, whether it's for healthcare or anything else, is to come armed with good information. As radiologists, we like to believe that we're the experts in imaging, and I believe we are. But when it comes to helping our referring physicians and our patients make decisions between services based on their costs, we do pretty poorly. Recently, my colleagues at Emory and I surveyed radiology residents all across the country about Medicare prices for common studies. You see them listed here. What we found was not surprising. Radiology trainees did extremely poorly in estimating Medicare prices. Only 18% of their estimates were within 25% of the correct Medicare price of those services, and fewer than 1/3 were within 50% of the right price. Medicare prices and private insurer prices for services do indeed vary, but I think this nonetheless illustrates how poorly informed our trainees are in this regard. And I'm not just picking on trainees. I have no reason to believe that residents and fellows somehow magically get better after they graduate and go off into either private practice or academic practice. Non-radiologists perform even worse. In a survey of all trainees at Emory, from pediatrics to medicine to surgery and everything else, only 6% of estimates were within 25% of Medicare prices, and only 1 in 6 were within 50%. So we can't just assume that our referring physicians know this information when they're making decisions with their patients about what examination to choose in a particular situation. But let's put this in perspective. Patients want this information. They are increasingly seeking this information. Here are some data on relative Google searches for the simultaneous search for costs and MRI. You can see that these searches have grown dramatically over the last 15 years in this month-by-month comparison. So what do patients find when they do these searches? Unfortunately, the information isn't particularly helpful. Angie's List, for example, gives a pretty broad range of prices and doesn't break them down by body part or type of insurance. The Healthcare Blue Book provides cost rankings, but it's not really clear, at least to me, how one determines a, quote, fair price. Are those list prices, paid prices, insurer payments, or patient copays? I don't know. And there's no mention of the quality of services. There are big differences in image quality between 0.5 Tesla and 3 Tesla MRI images, and often big ones too in interpretation quality. I'm sure you've seen high-quality reports and some not-so-high-quality reports. That information isn't reflected at all in most of these types of ratings. Much of the problem relates to the terminology that is used, and often incorrectly, without a nuanced understanding. Cost, charge, and price are words that are often used synonymously, but they have different meanings, and they mean different things in different contexts. Let's take them one by one. When somebody says cost, it means different things to different people. For facilities and providers, it typically reflects the expenses incurred during the delivery of services, and it includes both variable costs, for example, supplies and salaries, as well as fixed costs, such as rent, lease, and taxes. Cost for payers refers to the expenses incurred in processing claims. That means making the payments to you and me as providers and facilities, as well as the administrative overhead of processing those claims. For patients, most of the time cost means their expenses paid out of pocket by themselves, not covered by their insurance. So one thing I challenge you to do every time you hear the term cost is to ask yourself this question: cost to whom? Costs differ depending upon your vantage point. But for relativity purposes for radiologists in day-to-day practice, trying to help their referring physicians and their patients make a decision between, say, an ultrasound and a CT, or a CT and an MRI in a particular situation, Medicare allowable fees are a good benchmark of whether things cost more or less and to what degree. How about charge? Well, again, this means something very different. It typically means the amount that providers ask to be paid, that is, the amount that you see on the first bill that you received. It refers synonymously with sticker price or list price, and charges are typically highly inflated when compared with actual costs and actual payments. Providers leverage this during their negotiations with payers for discounting purposes. So they may say, hey, our prices are $10,000, but we're going to give you a good deal and just charge you $2,000. But those same, sometimes huge discounts are rarely offered to patients when they're paying on their own and out of pocket. And price has a number of different meanings as well. Price is a general term, and again, it depends on the context. So sometimes we're talking about the charge price, again, comparable to buying a car, sticker price, or a list price. But in most of the time, we're referring to the price paid. And that's the amount paid by the insurer plus the amount paid by the patient, that is, his or her out-of-pocket payments. Let's drill down on that last slide a little bit more. So third-party payers may include Medicare, Medicaid, Blue Cross Blue Shield, and a variety of other payers. They may or may not pay for individual services and to various degrees. Patients, well, their share varies quite a bit. If they're uninsured, referred sometimes in the industry as self-pay patients, they may pay as much as 100% of their charges. Those with generous coverage, those gold plans that are out there we've heard much about, pay much less out of pocket, but either they or their employers will pay much more upfront for those policies. Those instead who have less generous coverage, for example the bronze plans, will pay considerably more out of pocket, and even a lot more yet if they get their care out of network. Let's take, for example, a shoulder MRI, which for the purposes of illustration we'll say costs, say, $500 total when you add up the professional and technical fees. That's the radiologist share and the hospital share. We'll talk about those two components in a future module. Most of us are used to copays and insurance when we get medical services, so that $500 MRI might mean a $100 payment for the patient with the remaining $400 paid by the insurer. Or it could mean that the patient pays the entire $500, or that the insurer pays the entire $500. It varies a lot. How can this be? There are a lot of things that come into play here. So let's walk through a few of them. First, does the patient have insurance at all? Because if he doesn't or she doesn't, then they're probably paying 100% of the costs of their health care. Have they exhausted their deductible? Most of us have high deductible plans anymore. And so if you're still within the first $2,500 of your healthcare expenditures for the year, you may be paying full freight. Now, once you've exhausted that deductible, now we're getting into some other considerations. Did you receive that service in network, meaning with a preferred provider? Because if you didn't, you may be on the hook for the entirety or up to the entirety of the payment. Now, if you did, we get into a whole bunch of different considerations. What type of service? Because sometimes the payment by the insurance company, and therefore the patient's copay, varies a bit. So for office services, there's frequently a copay. Some plans say $25 for a primary care physician and $50 for a specialist. If you go into an ED, emergency department, there may be, say, a $100 copay. If you get a diagnostic test, such as imaging, you may be subject to considerable coinsurance. And if you get hospitalized, again, it depends a lot based upon your plans. You may be on the hook for a lot, or as I'll show you an example in a moment, none at all. Since plans provide coverage on an annual basis, what a patient pays and when they get their services differs quite a bit. In January, few if any patients have met their deductibles for the year, so they may pay as much as 100% for their imaging services. By December, depending upon their plan, they are much more likely to have exhausted all of their deductibles, copays, and coinsurance responsibilities. That's why many of our practices see, for example, a surge in screening mammography near the end of the year. Savvy women know that they have a 10% likelihood of being called back after they come in for a screening mammogram, and often defer those elective studies until late in the year to make sure that those follow-up diagnostic mammograms and ultrasounds are paid for by their insurers and not them. It can be complicated, even for somebody like me who likes to think he's savvy in this area. Here are some payer explanation of benefit statements, the jargon is EOB, for my daughter, who granted me permission to share her bills for teaching purposes about services she received here in Atlanta for her complicated appendicitis. For initial CT scan, you see here, We, as the family, paid 100% of the fees to the radiologist and about 80% of the fees paid to the hospital. Now, she had a follow-up CT scan, exactly the same CPT code, exactly the same service. And you can see that her financial responsibilities were quite different. At this point, we paid only about 20% of the total amount to the radiologist and 0% of the amount to the hospital. That is, the insurance company picked up the full tab here. And to make this even more interesting, while the insurer required variable coinsurance for portions of both of her imaging tests, her surgeon was paid fully by the insurance company, as was the hospital for her entire admission, without any copay requirements on her part. I don't have a good explanation for you about this other than to say this: it's complicated. And we're healthcare professionals, and we're supposed to be savvy in these things. It's not a stretch to anticipate that a patient who struggles with all the nuances of copays and coinsurance may be asking why imaging services cost so much and why their surgery is, quote, free. Again, it gets back to my earlier challenge to you. When you're talking about costs, always ask who is paying, because it matters a lot. Because insurers typically have higher patient copays and coinsurance amounts, as you saw in that last case for imaging, it's no surprise then that imaging has received a lot of attention in this regard. The news outlet Vox.com is collecting information from patients on prices for all sorts of healthcare services. You can see here the bill sent in by a patient that led to this story about a pediatric MRI examination performed at a prestigious medical center in California. The patient responsibility was almost $24,000 for an MRI. And if you're surprised by that, as a physician, it's pretty easy then to understand why the patient's family reacted the way they did. We'll continue to dig deeper into charges and costs and prices over future modules. But as I wrap up this module, let me challenge you to regularly ask yourself a couple questions every time you're asked about the appropriateness of a study or asked to protocol a study. Did the patient need a study at all? And does the patient really need this study? And that's in the protocol phase of things, assessing appropriateness. When you're interpreting examinations, ask yourself a couple more studies when you're making your recommendations and dictating your report. Does your patient really need a follow-up study? And are you conveying the appropriate level of certainty in your report? Because if you're using a lot of weasel words and conveying ambiguity, referring physicians may choose to get another study. Not that it necessarily adds more, but because you've instilled in them a low level of confidence. And remember, when patients get more tests because of what you do as a radiologist, they typically see bigger bills. So in summary, for healthcare services, charges and prices paid are often very different. There's unfortunately little transparency today in healthcare pricing, and very few of us know much about costs. For imaging services, patients typically incur substantial out-of-pocket costs. So as our society increasingly focuses on the costs of healthcare services, opportunities abound for radiologists to take meaningful and valuable roles in shared decision-making moving forward. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Replete.